heard it? Yes? Just saying. 3 episodes of wheezing this week, and her parents have brought her in for an asthma office visit. When taking her history, it is found that Jamie has diagnosed with atopic asthma at age 10. Jamie tells the physician that she has used her Prevental inhaler once a day on 3 separate days this week to control her wheezing and shortness of breath. She uses no other medication. When questioned about her activities, she stated that she likes to ride horses, and her parents had purchased a horse for her last month, which she named Trigger. Although she had been riding daily, she has felt too fatigued and short of breath to ride this week. She complained of waking up at least 3 times this month with shortness of breath and wheezing. A bedside PFT was done in the office and shows that Jamie's FEV1 is greater than 80% of predicted. So based on the diagnosis, when she was 10, what classification of asthma does she have? Yeah, don't press your phone. Extrinsic, right? It's an allergic type. That atopic was the key word there. Which of the following is most likely to be associated with her hypersensitivity to an antigenic agent? Time to get rid of the horse. How would you classify her asthma severity? We may not have actually talked about this yet, but like that makes a difference. You know, I said the test was cumulative for the whole program. I didn't fail to tell you that includes next year. Is fair in my vocabulary? Apparently not. You think it's intermittent, and we'll see where she comes out as. Okay, this is what kind of the author looks at as far as a diagram of the different pathophysiology that is changing here. Key characteristics: smooth muscle constriction, causing the airway caliber to be reduced. Combine that with swelling, and you can see the epithelial layer is thicker than normal, and also an increase in mucus production both from the submucosal glands and from the goblet cells. Okay? So those combination of 3 things are kind of the hallmark of bronchial asthma. Signs and symptoms vary quite considerably from person to person and can vary from an attack to an attack. Sometimes it's just an intermittent cough. Sometimes that cough is joined with some wheezing and some shortness of breath, chest tightness. And the key part here, remember, is that this only occurs during the physical attack. Otherwise, pulmonary function is normal. If you take an asthmatic who is not currently having an exacerbation in an episode, it's going to be perfectly normal PFT, typically. Okay. On physical exam, what do we end up seeing? Well, we end up seeing a patient who has a rapid respiratory rate and a rapid heart rate. again responding to the fact that they're probably hypoxemic. Like COPD patients, they assume positions that facilitate ventilation by using the tripod position. They transiently will have hyperinflation. Again, once that resolves, you won't necessarily see it, especially the rib distances. They may be using pursed lip breathing and accessory muscles. On percussion, it's hyperresonant, and you can see a variation of blood pressure, systolic blood pressure by 10 from, what is pulsus paradoxus again?
Pulse.
Varies with respiration. So there's a difference between inspiratory blood pressure and expiratory blood pressure. Persistent cough, there is a special type of asthma that is unique, and it's called cough variant asthma. These patients don't wheeze, but they have a very distinctive, almost a barking cough when they go into an attack. It's once you hear that cough, you'll go, "Do you have asthma?" And I'll go, "No, really." And the cough does go away with bronchodilator therapy, same as the other ones. They may only be able to speak in a few word sentences. That's usually a sign of extreme dyspnea, that they have a difficult time speaking. Remember, vocalization only occurs during expiratory, and they have an expiratory flow limitation. It's going to be very difficult for them. Peak flows and FEV1s, so our measurement during an acute attack, they will be low. Wheezing, obviously, will probably be present. If you have a patient who has wheezing and then subsequent to that there's no wheezing, that usually is a very bad sign, because that may mean that there's going from limited airflow to no airflow. So I've got to be careful how to take the fact that wheezing is resolved as being a good thing. Now, obviously, if they're improving their airflow and the medication's working, blah blah blah, different story. But got to be careful on that one. We talked about the other ones there. Eosinophilia is common in the blood, and technically, if you were to look at the sputum, you would end up seeing some eosinophils in that also. If there is any kind of a suspicion of an infection present, because an infection can trigger an asthmatic attack, doing a culture and sensitivity to identify the causative organism. And we talked about if there is an infection, obviously the white count would be up. And if you were to measure the serum antibodies, the IgE would be elevated if it's an allergic type reaction, because again, that's the hallmark as far as what process goes on. It is a obstructive defect, as we've said, where there's an airflow limitation, specifically on the expiratory phase, although it can be on both. During acute exacerbation, they have a lot of trapped gas exhibited by an increase in RV, FRC, and TLC. Typical obstructive flow volume loop, where you end up seeing that scooped out portion in the mid to small size airways. And again, they would have a difference in the slow vital capacity from the forced vital capacity, because that dynamic compression plays a role there. There is, in patients who we are unsure if they have signs and symptoms of asthma, but their pulmonary function data is not indicative of asthma. So where do we go from that? Well, the option we have is to do what's called a methacholine challenge, where again we're giving a cholinergic agent to promote bronchial constriction. So it's called a bronchoprovocation test also. And we're looking for a drop in FEV1 by 20% from baseline, and we basically just give scaled doses of methacholine, a little bit more, a little bit more, a little bit more, until we see that 20% drop. In patients without reactive airways, you won't see a change. And obviously, we're not going to do a PFT during an acute attack because it's kind of stupid. We know it's bad. We will monitor FEV1, and we will monitor peak flow, especially when you are trying to, as far as getting a baseline. Okay, a lot of people have a variant opinion on this, but when an asthmatic comes into the ER, it makes perfect sense to attempt to try and get a peak flow reading to see where they're at, to see if there's improvement. I recognize the fact that the primary aren't going to do a real good job, but we need to have some sort of a baseline to go on. Chest X-ray, again, would show a lot of trapped air, flattened diaphragms, intercostal spaces widening, all the normal things you would expect in somebody who's hyperinflated. Again, otherwise, when they're not in an acute exacerbation, it's perfectly normal chest X-ray.
Rick, their intercostal spaces will go back too?
It's just basically the ribs stretching out a little bit because of
But
it.
I thought that once the cartilage was stretched, it wasn't going to go back.
No, it'll go back to normal.
Okay.
COPD probably never will. Asthma, it's not as pronounced as a hyperinflation that you end up seeing. Okay, remember that acute on chronic? Similar kind of picture here. And this is why, as I'm going through this, I'm going to say that blood gases are not a good index of how severe the attack is, and you'll see why. Mild asthma, they have a little bit of hypoxemia because of some VQ imbalances, so they hyperventilate. PCO2 goes down, pH goes up. The hyperventilation, the respiratory alkalosis can also just be caused by anxiety, the feeling of shortness of breath, whatever else is there. Once you start having a little bit more severe, again, you see that you may have the hypoxemia, especially if there's a pneumonia that's the triggering mechanism. Then they come back to normal as far as their acid-base balance. So it's a similar kind of thing where they've gone from a respiratory alkalosis and now they're starting to fail, so their blood gases actually look okay. Does that make sense? At this point now they're starting to fatigue, so their ability to hyperventilate is no longer there. The PCO2 starts rising. And if we were to draw it at exactly the right time, we would see a pH and a PCO2 that's normal. And then eventually what ends up happening is they hypoventilate further, CO2 rises further, now they become the classic respiratory acidosis. But this is at the very poorest of stages. So really the better index is to monitor peak flow, or better yet even FEV1, because they could be in that spot where the blood gas looks normal, but they're actually in a world of hurt. Does that make sense? Okay, it's kind of
The same explanation that you gave for COPD.
for the acute on chronic, yes, where they hyperventilate from their normal. In this case, their normal is normal, but they hyperventilate and then they tire. And as they cross back over, if you catch them right at that middle point, it's going to look like a perfectly nice blood gas, except for the hypoxemia. So again, normal ABGs, low flow rates, bad sign. It's a very severe asthmatic attack. Things that lead us to asthma that or could be precursors to patients who have an asthmatic attack that they do not recover from and they die from. Patients who have had a respiratory failure requiring intubation and mechanical ventilation in the past. They're high risk. We know that they probably are not managing their asthma super well at home, so when you see them coming in that they need to be intubated again, that's a bad sign. If they have seizures secondary to the hypoxia, so they let it go so long, they become so profoundly hypoxemic that their brain basically doesn't have the oxygen it needs to function, and they start seizing. Patients who are obtunded, not responsive, bad sign. Patients who disregard their asthma symptoms for whatever reason, depression, drug abuse, anything where they're not managing their asthma symptoms. Fear of steroids. When we talk about kids, you'll see that as being more of a parent's fear than a child's. And patients who have pneumothoraces happening simply because of the trapped gas. Why we would want to hospitalize them, these are just some common sense things. Consciousness, that's no, they're not as quickly responsive. That choppy speech that you'll end up seeing. Someone who doesn't have good air exchange, you can't hear air movement because the wheezing is so bad that it shut itself down entirely. Most of these make common sense. 50% less of personal best. Acidic blood. Those are all signs that the asthma attack is pretty severe and needs some additional monitoring. Treatment for this, certainly oxygen and inhaled. Oh, this is the inhaled medications and the crying. Do you have that block? Oh, okay. Wasn't sure if I included it in there. I think we were talking about when we talked about medication delivery that a child crying, the method of their ventilation is these choppy inspiratory phases with this prolonged choppy exhalation, not very conducive for inhaling medications. So if you're ever looking for a reference that somebody says, oh no, you're wrong, here's an article for you. They may need immunotherapy as far as identifying what triggers they end up having an asthma measurements. Much of what can be controlled is the environment that they're in, so looking at what kind of house. These are the folks that actually would benefit from having their ductwork cleaned out of dust, because that commonly is a trigger. We try to do everything we can to not intubate, mechanically ventilate them, but if it's that bad, you need to sedate them and intubate them and put them on there. And influenza vaccines, they're a candidate for it. The medications we're going to have are divided into those two groups. The quick relief relievers, and the long-term controllers. So a reliever medication would be something like your fast-acting beta agonists, all the ones that we had on the last farm test, I think, weren't they? Pretty much, most of them at least. Looking at your SABAs, your short-acting beta agonists. Perhaps anticholinergics along with that, although the anticholinergics seem to work better with COPD than they do working with asthma. You can do a trial of them. And then as far as a quick relief, steroids, but this would be steroids that are IV, typically, because the oral even takes a little while to get on board. Long-term controllers should include an inhaled corticosteroid, possibly also a long-acting beta agonist, the LABAs, non-steroidal anti-inflammatories. We'll talk about them when we come to that. Perhaps methylxanthines, which is as we'll find in the farm. These are the side door drugs, and then also the leukotriene modifiers work in some subgroup of asthma. As far as IV steroids, the most common one you'll end up seeing is salumedrol, although orally you can get prednisone and prednisolone are options also. There's one unique drug that is out there, and I'm not even going to begin to. It's called Xolair. Omalizumab. Okay. And this is a drug which is specific for patients with IgE that are in the severe persistent state. So these are the really difficult to manage atopic asthma patients, and it's a drug which basically treats that IgE elevation. It's an inhibitor of IgE being released. It's an IV medication. It's something they come in for. I think it's every 6 weeks. They come in for another shot, and it basically keeps that IgE suppressed. And as the IgE is suppressed, you don't have the persistent feature to the asthma. Some other weird stuff that is out there. Magnesium, and we'll see that mag sulfate is actually nebulized as a mechanism to prevent the destabilization of mast cell further. Heliox, again, the low density gas allows for airflow to bypass the obstructive elements and, in theory at least, improve ventilation. And then there's a relatively new, first of all, tiotropium is an anticholinergic that can be added to the short-acting beta agonist. I'm sorry, as a long-acting agent, you can use tiotropium because this is actually a maintenance. But this bronchial thermoplasty is kind of interesting. I was at a conference talking to the doc one of the docs who does this, and what they basically do. Let me see if I got a picture of it here. But the doc made a comment. It was an interesting comment. He said the smooth muscle that surrounds the airway really serves no purpose after birth. Why would you want to have those airways constrict? And prior to birth, you're not ventilating, so you want to keep the airways intact. But once you're born, there's not really a need for it. So what this mechanism does, is this a video? No. Is it basically uses sound waves to eradicate the smooth muscle that's surrounding the airways. And what they do is they go down as far as they can with this, it's a thing that's inside of a bronchoscope. They they take these wires, come back, and it'll put sound waves against the wall, which basically destroys the smooth muscle. They do it in one spot, they move back a little bit, do it again, move back a little bit, do it again, move back a little bit, do it again. And though it's basically a three series where they do the right lower lobe, the right upper lobe, and the left lung. And it's about an hour and a half procedure that they end up doing to eradicate the smooth muscle. It's pretty cool.
How effective has that been?
It's only for the very severe asthma, and it's been shown to be more or less effective. But they reserve it only for that group. They can't be managed any other way. Yeah, it is. And there's only a handful of centers that do it, and I think Henry Ford may be the only one locally. I could be wrong. U of M probably does it also. I probably shouldn't stabilize that one.
So was he at the point by saying that it's not like use for this medicine?
Yeah, I mean, if you think about it, why do you need to have that smooth muscle constricting? The premise, I guess, is that it's a defense mechanism for the asthmatic so they don't inhale these allergens. But causing the airway to constrict like that seems like a rather drastic route to end up going for that. So, I don't know, this was an interesting, I had never heard that theory before. So.
Once they have that procedure on the use of medications for them would probably be
Drastically reduced, yes. Some other stuff that is out there using ketamine, which is a sedative, used a lot in vet tech medicine, but by putting them into a deeper state, you can ventilate them easier, especially, this is for the status asthmaticus, the patients you can't do anything else with. It's so difficult to ventilate them. Using anesthesia, halothane and fluorine are a couple of anesthetic agents, and using them with ketamine and, I don't know if you've ever heard of this drug before, propofol. That's a joke. Diprovan. It's a drug which puts you into a hypnotic state, if you will. The use of nitric oxide, and I'll talk more about nitric oxide another day. And looking at some other stuff, that nebulizing lidocaine is a drug we can use to desensitize for pain, but it also, if the problem that we're seeing is that it's a vocal cord issue, sometimes that can end up being beneficial. And then the most drastic way that we can end up treating ultra severe asthmatic is through something called extracorporeal life support or extracorporeal life I'm sorry, extracorporeal membrane oxygenation is what the ECMO stands for. But basically, it's a process where we take blood out of the body, run it through, in essence, an artificial lung that removes CO2, puts oxygen in the bloodstream, and you put it back into the person. It's, pardon me?
Blood doping.
Oh no. This is what goes on when they do open heart surgery. Obviously, when they do open heart surgery, you got to stop the heart. Kind of hard to change a valve when the heart's pumping. So they'll take and just bypass everything. It's cardiopulmonary bypass. Well, this is done at the bedside, and you're basically taking putting a catheter into the common carotid, taking a catheter, putting it into through the internal jugular into the right atrium, drawing blood out, putting it back in again.
That's
After
what
one
an
strip.
RT would do, right?
Actually, yeah. Actually, children's. I think Beaumont's starting an ECMO program. William Beaumont, Royal Oak, and U of M. Yeah, RTs are one of the group of people who end up taking it on as an extra load. And ECMO has been defined as 11 hours and 58 minutes of boredom and 2 minutes of panic. It's the most boring thing in the world. You're sitting there watching the pump go around, blood go, until something goes wrong and all hell breaks loose, and it's like, shit! Yeah.
So with that, is that just a treatment that you?
This is severe. This is the worst asthma attack you could ever possibly happen.
How long would they be on that life support?
Until they can get the asthma resolved.
Okay, so that would be just like a.
Yeah, it's a bridge. Yeah.
I didn't know if it was just like a
No.
treatment.
No. This is something that we're basically taking a load off the lungs and figuring out how to fix the lungs or to allow it to ride out before you go back. Methylxanthines, I think we talked about that previously, but 5 to 15 micrograms per milliliter is the blood serum therapeutic level. And again, those methylxanthines, like theophylline, have a very low therapeutic index and can lead to problems if they're not monitored effectively. So what do we want to look for? Again, the big thing is looking at pulmonary function. If the patient's at home, correlating changes in their pulmonary function with activity to help diagnose or help identify what the triggers could end up being. So that's why having a patient keep a diary. And also just bearing in mind that just because you heard a wheeze doesn't mean it's asthma. Could be a foreign body obstruction, could be a vocal cord dysfunction, could be tracheal stenosis or due to tracheal malacia, some other damage to the tracheal wall. Got to rule everything else out. Okay, so this gets into how we classify the severity and the control.
And for right now, we're only going to focus on the adult. I give you tables for young children, and this is components of severity, and this is components of control for the same patients. Again, I'm not going to worry about kids. You can go back and look at that at some point. For right now, let's just focus on the adult. That is there. Okay, so what we're looking at are basically 4 different classifications. And as we go through, you know what, let me just go ahead and go skip through this. And there's one for 5 to 11 that we'll just ignore for now. And this is the one we want to focus on. Okay? So classification of asthma severity in youths greater than 12 and anyone else above that age. Okay? And there's 4 different classifications that exist: intermittent, mild, moderate, and severe. And if you'll notice, the latter 3 are all classified as persistent. So it'll be mild persistent, moderate persistent, severe persistent. And then we look at degrees of impairment and degrees of risk. So in this case, if we look at their symptoms, how often are they exhibiting symptoms, If it's less than 2 days a week, it's intermittent, greater than 2 days but not daily, daily throughout the day. You can see it's getting more severe as you go up in that level. How often are you awakening at night? Less than 2 times a month, 3 to 4 times a month, less than once a week but not nightly, and then often nightly. How often are you using your rescue inhaler? Less than 2 days a week, greater than 2 days, but not more than one time a day, using it daily, using it several times per day. How much is it interfering with your normal activities? Not at all. Minor, some, extremely limited. And then looking at your quantifiable data as far as your FEV1. And here you see basically normal looking PFT data, and then we're getting to where we're below 80%, 60 to 80%, less than 60. Okay. And then looking also at exacerbations, never had one to maybe one, and greater than 2 or more, we're considering that persistent, and that makes them a high risk. Yeah. So those are severe. That's how we're going to classify the severity. What I would anticipate happening on a test, not this next test, but the test after, is I'll give you a scenario and you tell me what the severity is. Okay? And then also we want to look at how well is it controlled. So I have a patient who's mild, persistent. Is it controlled well or not controlled well? It's kind of the same things, looking at the symptoms, looking at how often they awaken, how much does it interfere. And the goal should be, regardless of the level of asthma they have, to have a well-controlled situation. So ideally, they're never someone who's missing school for a kid or missing work as an adult. They're able to rarely, if ever, utilize or need their short-acting beta agonist. And this questionnaire there's a couple of different ones that relate to the level of dyspnea that they feel. So I'm not going to worry about how that's scored or anything, but if you have a desire to go and look for that, you can. What that does then is it puts us into a step process. And this is blown up for you in the back as a big hint. Okay. So if you'll notice up on top, you have intermittent asthma off by itself, and then persistent asthma where you need to have some daily medication. And it also says that at step 3, you probably need to be consulted with an asthma specialist. And step 4, if you're not already seeing one, you definitely need to be seeing it. And the idea here be that we move up or down depending upon the patient's response to therapy and depending upon how well controlled they are. So the step 1 is just basically looking at a short-acting beta agonist. So if they're just have a rare occasional attack, SABA will be enough, along with patient education, control of the environment as far as identifying triggers, and managing any other comorbidities they may end up having. Does that term make sense, comorbidities? It's other stuff that's wrong with you that complicates the management. And they also say once you get into the persistent, perhaps looking at some immunotherapy, identifying the triggers and going through a process of desensitization. Okay. Okay, then you move up to step 2, and this is really where we're starting to look at mild persistent. Again, starting them on a low dose inhaled corticosteroid. Because this was an expert panel, what does that mean? They never agree with each other. So some people said, well, I don't know, I might try them on a leukotriene inhibitor, or I might try them on theophylline instead. For our purposes, we're going to try to stick with the preferred therapy because that's the most logical.
Doesn't seem to be controlling it. You're still seeing symptoms. We move up to step 3. We add to that low-dose inhaled corticosteroid a long-acting beta agonist. Still not doing well. Step up to step 4, medium-dose inhaled steroid with the LABA. Up to step 5, a high dose plus the LABA. Step 6, the high dose plus the LABA plus a steroid. So you can see that we're adding something to the treatment as we're going along. And by the way, the corticosteroid is an oral corticosteroid. It's being put on prednisone. And then once you move up a step, moving back down is basically when those symptoms and all the other measurements are being controlled. Does that make sense?
In step 6, where it has the inhaled corticosteroid
Yeah.
and oral,
Yeah. So not only are you on a high dose of Pulmicort, you're also on corticosteroid orally.
So how often are these people, how often do they go for the visit?
6 weeks. Yeah. And again, this is where home monitoring becomes really handy to see how effective the therapy is working, doing peak flows at home. And it says here, step down if possible when the asthma is well controlled for at least 3 months. So, okay. So, intermittent asthma, mild persistent, moderate persistent, severe.
Like, how do you know? I mean, if it's being well controlled because of the amount of medications that they on, so how do you do it?
If you're being well controlled at step 5, and it's 3 months have gone by and you haven't had any kind of exacerbations and everything, you haven't missed any work, go back to step 4. Try backing it down. Because the goal really don't want to be at step 5 and 6. And reevaluate. You got it. So here's our little scenario that we had. If you take a look at your listing there, let's figure out where she's at. It's found she was diagnosed at age 10. She has used her Preventol inhaler once a day on 3 separate days this week to control her wheezing and shortness of breath. So what looking at the chart, not the step, but the other one. Persistent. Mild persistent? Okay. She uses no other medication. For a mild persistent, we probably should be using something else. She said she likes to ride her horses, and she purchased one last month, and she's been riding daily, but felt too weak and fatigued to short of breath to ride this week. So we're seeing a change in activity, right? So what's the one topic, one category they have there? Under the... An impairment, yeah.
She was riding it for a month, about a month ago, and just now this week, she's kind of had it like build up like that, and not have like an actual acute response.
Remind when we talk about occupational asthma, there's something, you see that a lot in that case. They go home for the weekend, their symptoms go away. They come back to work Monday, they're a little bit, Tuesday a little worse, Wednesday a little worse, Thursday full blown. It's pretty interesting.
like a minor limitation? I mean,
Well, in this case, I would put it mild to moderate, actually. If she's been too fatigued and short of breath to ride at all, that's getting a little bit more of an impairment. Complained of waking up at least 3 times this month. And then, but her PFTs were normal. So what you're looking for here is which tips it furthest to the right. And that's how we're going to classify them. So I don't even have to worry about going through this. Because then you let me anyways. Are you kidding me? I know. You know what? Let's take 5.
Her asthma probably, you could argue between mild and moderate persistent. But certainly it is a persistent. An example I would give you would be a little more dry, cut and dry. How well do you think she's controlled? And what should be added to her regimen? Now, you don't know these medications yet, so it's a little bit unfair. But what word was not in my dictionary?
Fair.
There you go.
We'll just make it not logical. I'm sure that's even secondary.
Good guess. Oral steroids we're gonna reserve for the most severe, so that's definitely wrong. Fluticasone is an inhaled corticosteroid, the ICS that we were talking about, and that's a low dose. Advair is an inhaled corticosteroid and a LABA, so that's a little bit of a higher step than she probably needs to be at. And Xolair is reserved for the very severe asthma that has unresponsive to everything else, and probably would not be her. Yeah. It's too high of a. That's step 3 or 4. So.
You know what, after having kids who have had asthma, the oral steroids is something that family doctors seem to prescribe when they first prescribe the inhaler.
Again, we've changed our management of it. I don't know how long ago that was. Wicked long ago. And our understanding of how to manage it has improved. Here's the report if you ever want to download it, and there is a to give you some examples of some different patients with asthma, and then there's the answer key there also. Okay, so you can practice. Okay. EPR3 couldn't come to a consensus as far as whether monitoring of symptoms or using peak flows were a better route to go. Some patients are very in tune with their bodies, and just by symptoms, you can know that there's been a change in their condition. Other patients, objective measurements are probably a little bit better for them. Either way, they need to be part of an asthma action plan. The action plan is basically telling the patient how they should be managed on a daily basis and what should be done when symptoms change. Really should be for any asthmatic, but if you're a moderate to severe persistent, definitely should be there. And it should include something as far as what goes on in school too. As far as daily management, what medications should you take, what names of them, and how to control the patient's environment. Kind of logical stuff. How to recognize and handle worsening asthma by looking at peak flow and symptoms, and what to do about it. So changing the asthma regimen when that happens. Using, and then looking at what peak flow or symptom level would need to have a call to the emergency room. And then also having all those numbers available so you're not scrambling for them. This is kind of what it ends up looking like. And it's got, their name and their physician's name and phone number and who completed it and basically the different things, long-term control medications, quick relief, how much to take, whether to take it every day, twice a day, 3 times a day, whatever. And here's our inverted traffic light that basically has some descriptions as far as I don't feel good and I feel awful. And you can see there's different things that are there. If you're in this zone, these are the things to add on to your regimen. Okay, so it gives patients a guide to be able to follow it. We talked about using peak flows, establishing a personal best over a 2 to 3 week period when they're feeling healthy, monitoring, recording it twice a day and then putting it into that traffic light. And there's actually within the peak flow meter box a little plan that they can plot out where their personal best is. And there you go with your 80 to 100, 50 to 80, less than 50. Green zone, everything fine, things are in control, take everything as normal. You use your short-acting beta agonist right away if you're falling in at 50 to 80%, because that's a caution. And red zone means you're in a danger zone. Take your SABA, but get to the doctor or the emergency room ASAP. We know how to do this. So an example here, you have a 33% improvement and a 400 milliliter improvement, so that's a significant one. And that's ideally what we're looking for, is post-bronchodilator having an improvement of less scooping out of the flow volume loop. A lot of asthmatics turn to alternative options outside of traditional medicine. None of the trials, first of all, they're all been very small, a lot of anecdotal stuff, nothing scientific, and so really they should not be used as a primary mechanism for management of asthma. Acupuncture, chiropractic therapy, herbal medicine, yoga. Relaxation techniques and breathing techniques and yoga probably are good adjunct during an attack, calming them down, having them breathe through their nose per slip, but certainly should not be the primary mechanism. Who's got a schedule handy?
They're not triangles, like you said.
Oh, no, people have been.
Well, no, I mean, you're not a triangle during a severe attack.
I hope not.
Like some of this start has some of these go with
All right, we gotta, we'll have to postpone doing the clinical sim, 'cause I don't have a computer ready. You know what? Let's do this.